Ever wonder what a military neurosurgeon does in a deployed environment? Our conversation with Army neurosurgeon Dr. Ryan Morton sheds light on how to deal with head trauma, which is often seen as the black box of trauma care. Avoiding hypoxia and hypotension and managing intracranial pressure are crucial for patient outcomes. And Dr. Morton describes how deployed surgical teams work together to optimize patient outcomes in the face of combat trauma. Thanks for tuning in to this bonus WarDocs episode exploring neurosurgery in the combat zone.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Well, I mentioned before, we've not really done this where we did a bonus episode, but I figured that since I had an Army neurosurgeon who's been deployed to Iraq, that we would test out a bonus episode where we specifically talk about neurosurgery and trauma and potentially cover a little bit of combat trauma, because I know that when I was deployed, particularly when I was at a Role 2 in southern Afghanistan, the head injury was the part that really gave me the most anxiety. Partly, as I mentioned in the other episode, it's sort of the black box. It's outside of the normal comfort zone of most medical providers. But luckily, the military has given a little bit more emphasis on it. So, Ryan, thank you. This is Lieutenant Colonel Ryan Morton. Ryan, thank you so much for joining us for this bonus episode and giving us a little bit extra more of your time.
Absolutely, Wayne. Thanks for having me.
So we mentioned in the previous episode that one of the most important things that we do, particularly for me as a general surgeon or when I work in a trauma surgery capacity in deployment, is we make sure that we cover the ABCs of trauma. And the way I understand that, particularly involving head trauma, is that we're trying to avoid easily fixed things such as hypotension, hypoxia, and other issues, and that comes before the D, of course, so CAB, ABC, and then D. Ryan, tell us sort of how you think about head trauma when you're dealing with a polytrauma patient.
Yeah, in the austere environment, head trauma should cause anxiety because you don't have the ability to image the patient. And so you're just guessing. And so anybody who is trying to make it sound any more highbrow than that is being disingenuous. So if you don't have a CAT scan, you're just guessing. But that's okay because there's a way to guess well, and there's a way to continue to try to optimize the patient's care. And you already alluded to it. By far and away, if you have a suspected head injury patient, and the reason why someone should be a suspected head injury patient is if their GCS is less than 8, that's considered comatose. An easy way to remember that is they're not following commands. So if they're not following commands, by definition, they're comatose because you can't have a GCS higher than 8 if you're not following commands. And usually they're intubated. But even if they're not intubated, if you're not following commands, they have presumed head injury. And so avoiding hypoxia and avoiding hypotension, it sounds almost too basic to be true. And it's like, well, of course, I'm not going to have that happen. But actively avoiding hypotension and hypoxia is different than just looking out for when that episode of hypoxia or hypotension occurs. It requires much more vigilance and some potential prophylactic therapies, bolus therapy, pressors, oxygen, that sort of a thing. And this all stems from a paper from one of my mentors, Randy Chestnut, who I alluded to in the last episode, who worked at Harborview, who came out with something at UCSD with one of his mentors, I think it was Larry Marshall, that showed even one episode of hypotension or one episode of hypoxia reduced the chance of the patient, a traumatic brain injury patient, having a good outcome by like 90%. And these were synergistic together. So this is by far and away the first thing that anybody with a presumed head injury should be on the lookout for from their providers, is that you actively monitor the blood pressure with an arterial line and you avoid hypotension, which the military CPG, I believe, says less than 100 systolic, but in civilian world or even at BAMC, I think we kind of use 90 systolic as kind of the marker for that. And then hypoxia is less than 90%, so 90-90. It's an easy way to remember it. And then once you're being hypervigilant about that, then it gets back to the empiric therapies that we talked about. If the patient has a presumed spine injury, you can reverse T them. You want to get the head above the heart. That dramatically increases venous drainage to the brain. And as a neurosurgeon, I can't tell you how many times I've seen just reverse T or sitting someone up it solves the ICP problem, at least in the short term, which is all you're looking for. And then after you've done that, put an end tidal monitor on them. We should have end tidal monitors downrange, and just blow them down to the PCO2 being 30 to 35, nothing in the 20s, but you don't want to be 45 because then you're vasodilated and you have a huge amount of arterial blood in the brain, which increases the volume, which bumps you up on the compliance curve. And then Monroe-Kelly doctrine, you start to shoot up. And then the last thing is sedation, 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 sedation. So if you have a presumed TBI patient that's intubated and they're thrashing all over the bed, like if you have anyone thrashing over the bed, they're going to be valsalvating, the pressure is going to skyrocket. And so you have to do everything you can to sedate the patient. So aggressive doses of propofol, fentanyl. If you have to use something else because you don't have those two, Versed is a decent one. Precedex is a decent one. Keeping in mind, you also don't want to induce hypotension when you're doing that. So it's a little bit of a balance. Trauma surgeons are experts at this. And then you can even start empiric therapy. You check, obviously you want to check the CBC, make sure that the platelets are okay, make sure that the coags are okay, check the TEG, and then check the sodium. And if the sodium is even normal and you're pretty convinced they have a head injury based off their GCS, give them a bolus of 3%, 250 cc's of 3%. If they're not hypotensive, give them that mannitol, gram per kilogram of mannitol. And then, of course, I haven't mentioned the obvious thing. You always want to check the pupils, right? So having a blown pupil is a horrible prognostic indicator, but there is a differential diagnosis for a blown pupil. So you can have orbital trauma. And so you get a traumatic optic nerve injury that will give the patient a clinical blown pupil with no intracranial hypertension. So there is a differential here. A blown pupil doesn't necessarily, particularly in someone who's had facial trauma, doesn't necessarily mean the end is near, but it is certainly very concerning. And it's something that you can monitor for a response. And, I've seen it in my career. You implement these measures, you give them the mannitol, and that pupil goes down. I mean, that's what a great feeling that is to see your treatment work and know that the patient is no longer herniating. And then you got to get them to a roll 3 so they can get a decompressive craniectomy ASAP if that's the case. So pupils obviously are super important. I think everybody learns that, day one in med school. Non-reactive pupils, even if they're not blown, terrible prognostic indicator. And then obviously a blown or dilated pupil that's non-reactive is the worst thing you can have. So sort of an emergency thing. We do teach craniotomy in an austere environment, exploratory craniotomy in an austere environment. That can be done by a general surgeon or by any surgeon. The way you make that decision, if they have a blown pupil, that's where you do the craniotomy on this ipsilateral side of the blown pupil. There are false localizing signs. So there's this phenomenon called Carnahan's notch, where during herniation, the brainstem gets pinned to the contralateral part of what we call the tentorial incisura. So you get a contralateral blown pupil. Very rare and nothing to really worry about if you're doing a craniotomy in an austere environment. You just got to go with the ipsilateral side to the blown pupil. If there's no blown pupil, but maybe you put a bolt in and the ICPs are 50, and you got to do a craniotomy, then you want to pick the side contralateral to the posturing. So if they're posturing on the left, that suggests that the right side has the pathology. So you would do the craniotomy on the right side. Doing a craniotomy in an austere environment is tough. If you don't have power, they have, a Hudson brace and a jiggly saw, but most of these places have power. And we do run through with the general surgeons on cadaver models, how to do a field craniotomy. At BAMC, I was very fortunate that particularly early, when I was early on in my practice, maybe because I was younger, but a lot of the general surgery residents would join me in the OR because we don't have a neurosurgery residency program.
And I've joined you in the OR before my deployments, actually.
Yeah, and you just get your hands on the drill, and I walk them through a craniotomy. And one of the most surprising things is when they're done with it, it's kind of like, well, that's it. And you're like, yeah, that is it. Like you're just taking the bone off, you're opening the dura, getting hemostasis, and then you're closing. Like this, as they say, it's not brain surgery, but it is brain surgery. But it's a very, very straightforward. It's a compartment syndrome of the brain. It's a fasciotomy of the brain is how you can think of it. You're just removing the skull, making sure there's no bleeding, and closing. Now, the hard part of the surgery is when you open the dura and there is a lot of bleeding, particularly from the sinus or the brain. And that does take some experience, some neurosurgical experience to know how to manage that. And that's the part where you can really get into trouble doing a craniotomy if you don't have that experience. But again, if you're doing a craniotomy in an austere environment, the prognostic indication on that is pretty poor anyway. So you're just doing your best for the patient.
Just out of curiosity, would combat gauze work on the brain?
I mean, it would work. You have to leave it in there, and then you got to get it out at some point. But yeah, I mean, it would work. You can pack the brain. It's just discouraged because obviously the underlying brain is likely going to be injured to the point where it's not going to recover.
Because it's dry from the combat gauze?
It's dry and probably hematoma building up underneath the combat gauze.
Yeah. Okay, so you mentioned that neurosurgery is a role 3 asset. I think that that's one of the things that I didn't fully appreciate, particularly on my first deployment, was that the neurosurgeon is at the role 3 because at the role 3, as you mentioned, is the CT scanner, right? The neurosurgeon needs the
Yes.
CT scanner. I mean, it's really that simple. But the neurosurgeon is also the theater neurosurgery consultant. And what I mean by that is if I was to go back in time to my first deployment, I would actually make sure I knew how to contact very quickly the neurosurgeon that was at the role 3 in Kandahar, because I would want to know who I can ask when I have a question involving neurosurgery. But I actually didn't know that I didn't know that I should try to get a hold of the neurosurgeon to get that information. But what my question is this though. Okay, so let's say that the medics at the point of injury, they've intubated the patient, they've put in bilateral chest tubes to make sure that they're not going to have a hypoxic event from a pneumothorax. They've bound the pelvis to make sure that there's no bleeding, and they've done everything they can for the extremities to make sure there's not going to be a hemorrhagic event. And now they have a head injury suspect, right? It's a mechanism. GCS is less than 8, as you mentioned. What other things would you recommend that they do? You said get the pressure up.
As long as they're on hypotensive, you want to reverse T them. I mean, when I walk into the trauma bay for a consult, when you're the consultant, the specialty, you walk in, there's a million people that want to talk to you. I mean, I'm literally just taking a beeline to the head of the bed and I'm putting the patient in reverse T every single time, because it's just not, unfortunately, it's not necessarily part of everybody's workflow, but you just want to reverse T because the spine is still okay. When you do that, everybody's worried about the spine, and I get it. The spine is important. You don't want to sit somebody up if they potentially have a spine fracture. You don't want to do that. I get it. But reverse T is totally fine, and it dramatically reduces the pressure in the head. Again, as long as they're not systemically hypotensive, where you may actually need to put them in head down in Berg is what I call it if you're really worried about the pressures. That's by far and away the first thing you should do. And then pop an end tidal monitor on. Most EMS paramedics role 2s have an end tidal. You want to confirm that you're actually in the lungs, and you actually can use that to get a number to potentially breathe them down.
So then now put yourself in my shoes. I'm at the role 2, and I also don't have any ability to image the brain, the intracranial structures. But what I do have now is the ability to perform surgical procedures to minimize bleeding, in particularly in the abdomen, potentially in the chest if those are the case, and then control or reconstruct any blood flow to the peripheral organs. But I'm also still really worried about the brain. But I don't have necessarily the skill set that you mentioned. But I want the patient evacuated quickly. What would you recommend that I do now?
Yeah, I mean, during your treatments, I'm impressed that you're keeping the brain in the back of your mind. A lot of time that's forgotten, so that's very good. I like that.
I do keep the brain in the back of my mind.
But when you have perfused bleeding, some of the things that can happen is you get very coagulopathic. Platelets can drop, your INR can go high. And so checking those things, the platelets and the INR, and transfusing, not just for your peripheral needs, but if you have a concern for head injury, it's the neurosurgeon famous 100,000 platelets is the perfect number. That's what we always say without a lot of data, but you want to keep those platelets greater than 100,000, and you want to keep the INR less than 1.5 if you think there's a head injury, to make sure that there's no expansion of that clot. So if you're just dealing with isolated, you have a leg, well, maybe you don't care if the platelets are 88 that much, or you just did a bypass. You're kind of happy that the INR is 1.8. But if you're really worried about head injury, you do want to transfuse to meet those numbers, and you want to check the sodium. So a lot of times these high volume resuscitations, the sodium can start to drop. And if the sodium drops, that's going to lead to swelling intracranially. So you want to be vigilant about the sodium. So besides the hypoxia and the hypotension, focus on normal blood coagulation stuff, and then normal sodium stuff, as well as reverse T. Will hopefully get the patient through that role 2 and on to a role 3.
Yeah, and that fits perfectly with balanced resuscitation. I mean, balanced whole blood.
Mm-hmm.
I mean, transfusions will accomplish all those goals, just as you mentioned. So now we get into your wheelhouse, right? So patient is now evacuated to the role 3, and that'll be a theater hospital of some kind that's got much more resources. Take me through sort of the neurosurgical evaluation of those patients.
Yeah. So The Role 3 hospitals, which were you ever able to see?
Yeah, I was in
you were
Baghdad. Yeah. Mhm.
They're amazing. I was expecting, I was expecting when I showed up, it was going to be like MASH. You'd be in a tent and then like there'd be some basic stuff. But there is a beautiful CAT scanner that is fortified, that puts out wonderful images. And then you have ICU beds and ventilators, and you have an OR that is, I call it semi-sterile. It is a wonderful place, and it's amazing what the U.S. military is able to put together in austere environments to make operating on these patients as safe as possible. But like you said, we got to get that CT scan. That's the whole point of the Role 3. You get that CT scan, you see what you're dealing with. Is it a mass lesion? Is it a not mass lesion? And you go back to the other episode. But once you determine that, then the next choice is, do I go to the operating room and remove the mass lesion, or do I put a bolt or an EVD in to see what the pressure is and try to treat this patient medically to keep their pressures down? At the same time, then you're getting a CT scan of the C-spine, the T-spine, and the L-spine to look for concomitant spine fractures that are going to determine the patient's mobility status, and also if they need a spine fusion. So a lot of times these patients have horrendously displaced spine fractures, very unstable spine fractures. And once their cranial situation is sorted out, the very next thing that we have to do is then go fuse their spine. Not an uncommon clinical situation to see.
What is the spine fusion process in the deployed environment?
Yeah, I was never put in the situation where I needed to do it, but my comrade in Afghanistan did at least 4 or 5 spine fusions in Afghanistan at the same time that I was in Iraq. And so they have the whole pedicle screw set up. They have lateral mass screws. They have everything you would have in America with the C-arm. There's obviously no navigation, which is a big part of spine surgery today. It wasn't back when I was training. So a lot of us that are at least 8 or 9 years out of training now still feel very comfortable putting in pedicle screws under fluoroscopy, but it would potentially challenge newer surgeons who have only used navigation. But nonetheless, you have C-arm and you can fuse someone in theater if needed. It's obviously not the best, most sterile environment in Baghdad in the Role 3, but it has been done with good outcomes. And there's actually a dog fusion was done the time for the surgeon before me fused a dog's neck. So these things have been done. It's amazing what we're able to offer in combat. But if you have a horribly unstable spine, you can fuse it. Now, usually if it's a United States soldier, and it's not like a spine that is so unstable you feel like a helicopter or a fixed wing transport to Germany would be unsafe. Most of the time, we're taking those service members and we're sending them to Landstuhl, where they can get the surgery done in a much more sterile and kosher environment. And they do a lot of spine fusions on trauma patients at Landstuhl or back in the States at Walter Reed or at BAMC. But there have been some done in the field on either Afghan nationals that don't have anywhere else to go and you need to treat them, or a horribly unstable spine that you feel like is not safe to go under any more transportation. You do it there in theater.
Yeah, one of the things that I'm interested to hear you talk about is, so when a patient's injured and you suspect a head trauma, at what point do you think that we should do some of the other things that maybe we don't come to mind immediately, like seizure prophylaxis and other things like that? Like when do you think realistically that should be done? And should we be afraid at any particular time to give those medicines?
Yeah. The trauma societies have guidelines on these things and they're all fairly uniform, but most of the time giving someone Keppra or giving someone Dilantin, if they're not actively seizing, should not be in anybody's priority list. Now, if someone is seizing, then yeah, they need to be getting, either 17 mg per kg of Dilantin, or they're getting 1.5 grams of Keppra as a loading dose. And then you got to monitor them clinically and not just give them paralytics, because you need to make sure the seizures are broken. But missing, 12 hours, like not getting seizure prophylaxis right away is not that concerning to me. It probably can wait till they get that CAT scan and confirm that they actually do have traumatic brain injury. That being said, if you happen to have 1 gram of Keppra on hand, it is an unbelievably well-tolerated medicine with minimal side effects, unlike Dilantin, which can have some potentially toxic side effects on the liver, or even if you accidentally injected subdermal, it's really quite caustic. But Keppra is very well tolerated. If you want to give 1 gram for seizure prophylaxis, most people agree that severe traumatic brain injury probably benefits from 1 week of seizure prophylaxis, particularly if the temporal lobe's involved, because the temporal lobe is the most eleptogenic. So if we have a CT scan and there's a decent contusions, particularly in the temporal lobe, I'll usually recommend a week of anti-seizure prophylaxis, even if they haven't had a seizure. If they've had a seizure, then they buy themselves typically around 6 months of anti-seizure prophylaxis with a neurology consult.
Interesting. So I guess my probably my last question for you is, when we think about you had mentioned earlier a story about a patient who had an injury to their carotid artery and they have vasospasm. When we think about a traumatically injured patient, do you ever see that there's a potential that the endovascular techniques to treat that vasospasm that you had mentioned before would be applicable on the battlefield? And if so, like where would be the best place to put that?
Yeah, so typically traumatic vasospasm, which is a real thing. There was a time in neurosurgery where there was some thought that it wasn't actually a real phenomenon, but I've seen it. I see at least 4 or 5 cases a year that are severe and they're refractory, meaning you got to keep bringing them back for more angioplasties. So traumatic vasospasm is a real thing. It can cause strokes and cause morbidity, but it typically doesn't start until sometime at least the 3rd day after the trauma. In line with subarachnoid hemorrhage vasospasm. And typically it's like day 7, day 8, day 9, day 10. That's like the real risk of the vasospasm. So most of these patients should no longer be downrange at that time period. They should be back at either Walter Reed or Brooke Army Medical Center, where they can be more accurately monitored with either transcranial Doppler or CTA. So I don't think there's necessarily a real role for cerebral vasospasm downrange. I think it's really the penetrating carotid injuries where you may want the ability to deploy a covered stent, where both neurosurgery and vascular surgery could kind of combine their powers and find the right treatment for the particular patient. As you know, when you put a covered stent in, though, you need to put them on antiplatelets. They need to be heparinized. So this is something where you're going to need a CAT scan beforehand to know if it's even safe. And you can also then, if it's not safe, they have intracranial contusions. You can do a radiographic balloon test occlusion, and just see if sacrificing the blood vessel, like I did with my patient in that story in the last episode, is a possible treatment option. Which for trauma, nobody likes taking blood vessels to the brain. In particular, it's not something where you want to do first line, but sometimes it's the only option to save the patient. And you want to know if it even is a viable option. And a balloon test occlusion is something that can be easily done with 2 access sites in range and can be done if needed. You just need the coils in the hospital.
So I said last question. I have one more question. So you did officer basic course as a medical student when you're in HPSP?
I did officer basic, yes, between I believe it was my first and second year of med school.
Let's say that when you finished, you were going to then be deployed after your intern year to be a GMO or flight surgeon or some operational job. Or let's say you did a residency in some non-neurosurgery field. What would you actually tell your younger self in that OBC course? What would be the take-home points for combat neurosurgery?
That's a tough one. I think that the main take-home point is probably the one that maybe your younger self needs to know, is you just need to know how to get a hold of the combat neurosurgeon. Because if you haven't had subspecialty training, you want to just be able to call that person up. And one of the beautiful things about the military and the DoD is that I feel like we're all a brotherhood, and that if someone calls me, particularly if you're in combat, sometimes there's this trepidation to call the subspecialist in the civilian world or advanced on, like, it's 2 a.m. I don't want to wake the neurosurgeon up for this. But when you're downrange, you got nothing else going on but the care of the troops. And so you can call me anytime, day or night. I will happily talk to you and any neurosurgeon who's deployed. We literally have nothing else going on but taking care of the patient. So if you have any concerns about a potential head injury, spine injury, just call the Role 3 neurosurgeon and run the case by him. And that person should be more than happy to give you recommendations on whatever case or whatever is troubling you at the time.
Yeah, I think that would actually, I would say the same thing about vascular surgery, orthopedic surgery. I remember when I was at the Role 3, just like you probably had at your Role 3, people would call me and say, I've got this vascular injury. I've got this, whatever. What do you think?
Yeah, I got this E2 that is just, he seems to be stumbling around the barracks. He seems off balance. Like, is this something to be worried about? And you're like, yeah, like that's not normal. Like, get him here. Let's get a CAT scan. So like, oh, I didn't know you would say that. It's like, well, yeah, of course. Like, we got to work this up. And so I think some of the trepidation for calling surgical subspecialists should be, and I think are completely eliminated in the combat atmosphere the way it should be. And we're all there together to help the troops get a good outcome.
Right. Well, thanks again, Ryan, for this bonus episode. And again, thanks for spending however long it was that you were in the military.
16
a long
years.
time.
Yeah, absolutely. It's been a wonderful career path. I recommend it to anybody. And it's really given me the best memories I could have asked for.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on WarDocsPodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.